Thank you so much for inviting me in present this topic, CD4 responses in trial of HT patients. Here my disclosures. We know that there is an evolving definition of HT patient. These are the data coming from Eurocida study group showing that with a composite definition of HT, we can assume that 10% of our patients may be classified as HT, and more than 1,000 individuals become HT in the period from 2010 to 2016. The more important finding to me is that the CD4 nadir is independently influencing the risk to become HT patient. And looking at data coming from Italy, we know also that HT patients usually have multi-drug resistance experience, and among patients with virological failure in Italy, we could assume that 99% of them have a triple drug class resistance. So a measurable portion of our patient with a lot of issue. In the Prestigio registry, we have enrolled patients with 4 drug class resistance. And as you can see here, making the story short, we know that ACV infection is present in 20% of them, that nadir CD4 is quite low, that the 40% of them have a prior diagnosis of AIDS, and that at the inclusion baseline, not always the severe immune the multi-drug resistance is related to the severe immune deficiency. You can see here that CD4 at the baseline, at the inclusion in the registry, was 346, 169 the first quartile, more than 600 the third quartile. And why present this data? Because these patients, HT patients with a multi-drug resistant virus, are present as a real challenge in today. And we see here that the ability of progressing to AIDS is related to the number of CD4, and these patients are at risk of AIDS event or death in more than 8% of the cases at 48 months. And more interesting, they have a risk of developing new non-AIDS event or new non-AIDS related death at 14 months. The probability is more than 15%. So really frail population. And what the trial of highly treatment experienced patients tell to us, we have a different trial during the years, different definition of HT patient, different design of the study, different outcome, but we can try to reassume some more important finding. The first one is benchmark studies. Benchmark studies show to us that the virological response in the first year is associated with the immunological response during the long term. And if you can see here, you can see the characteristic of the study design. The mean change in CD4 cell count continuing to increase in patients with always undetectable viral load or low-level viremia. That means in this study, lower than 400 copies, because they reach 244 and 286 cells for cubic millimeter. Why in the non-suppressive group, the mean change in CD4 peaked at 125 cells and then remained stable. So the virological response, more rapid the virological response, more possibility to increase in the time our CD4. And we have a different, we have data from the TORO studies. TORO studies was an open label study with a different design from benchmark study. The randomization was 2:1, and at 8 weeks, patients were able to receive enfuvirtide in association with the background regimen if they were failing. And you see that in a TORO study, we see a really robust CD4 because we reach an increase of 166 CD cells at 96 weeks in patients who were able to stay on enfuvirtide plus optimized background until 96 weeks. DUET trial is a randomized, double-blind, placebo-controlled study. Patients were randomized to receive etravirine, 200 milligram twice a day, in combination with darunavir-ritonavir, and this combination was offered starting from 24 weeks to all the patients had the possibility to receive this combination. And here we see that the increase we observed at 96 weeks is 128 CD4 in those receiving etravirine plus optimized background, and 86 in those who received for the first 24 weeks placebo. We have also the finding from Motivate study. Motivate study is a particular study because it was focused only on patients with R5 virus, more than greater than 5,000 copies ml, and experience or resistance to at least 3 antiretroviral class. More than 1,000 patients enrolled in these studies, more than 400 receiving Maraviroc 300 milligram QD, 426 receiving Maraviroc BID, and 209 placebo. And we have to outline that investigational drug in this study was excluded, but there was a 25% of the patient receiving enfuvirtide for the first time. And at week 96, the median change from baseline was 89 and 113 per cubic milliliter in patient assigned to Maraviroc every day and twice a day. And we have now two studies. The current study we are discussing, TMB 301, it's a particular study because the number of patients enrolled is very low. We are talking about 40 patients with a very limited option and a viral load at the beginning greater than 1,000. So the definition is moving in this trial from the resistance profile to the patient to the number of active drug we can propose to the patient. And as you can see, for the 21 patients who complete the 96 weeks, we have a modest increase. The median increase in CD cell was 20. And I think we have to better explore the metabolism of ibalizumab, the problems related to the internalization of CD4 receptor conjuncted with IBA. And at the end, we have to present the results of the BRIGHT study. BRIGHT study is perhaps the more important studies we have at this day. We know that in the BRIGHT studies, we enroll more than 300 patients. The criteria was strictly related to the fully active drugs. So in the trial, we have to include patients with more than 400 copies ml and no more than 2 fully active drugs. We have a randomized cohort receiving fostemsavir against placebo for the 8 days of functional monotherapy. And we have the non-randomized cohort, including only the patient with 0 active drugs. And as you can see, patient with a diagnosis of AIDS in more than 80% of the cases. The increase of CD4 was really robust. We observe 205 cells increase at 96 weeks, and was important even in non-randomized cohort. And this, I think, is the first trial looking at the recovery of CD4-CD8 ratio. We know that this recovery is very important both for AIDS progression and for non-AIDS comorbidities, and we have an increase of 0.24% of the CD4-CD8 ratio in the randomized cohort. So there is a lot of attention to investigate if the attachment, the prevention of the attachment, the prevention of binding of the GP120 CD4 may be an independent factors able to enhance CD4 recovery. And we know there are a lot of data suggested that inflammation is driven by GP120 directly and indirectly. There is an upregulation and dysregulation of a signaling of the cells, epithelial dysfunction leading to leak of junction, and also a proposed mechanism of neurotoxicity. And I think we need to investigate if the prevention of binding between GP120 and CD4 is able to independently predict the CD4 recovery. I would like to conclude my presentation presenting one case of our experience. Case report at San Raffaele Scientific Institute, male, 48 years old, no diagnosis of AIDS. His problem was oral candidiasis and numerous evidence of herpes zoster. He started antiretroviral therapy in '93, and he had a problem of HCV infection, genotype 1. And as you can see here, the patient was exposed to all the antiretroviral drugs in the classes we have at the moment. In March 2016, the patient has 20 cells with more than 6,000 copies. And his regimen was an holding regimen with darunavir, ritonavir, dolutegravir, and 3TC. This is genotype from March 2007 to 2016. You can see here the mutation classifying him as a patient without fully active drug. I remember that was the patient has previously failed both enfuvirtide and maraviroc. And this is the results we can see after 5 years. And this slide showed to me that which can be the factors involved in this CD4 recovery. The patient start fostensavir with 7 CD4 recovery, and from week 96 is always above 200 cells, with some spikes in CD4 recovery that can be attributed to, I don't know, we can hypothesize different mechanisms. The adherence to the therapy, to the patient for the treatment, the fact that we decided to put an aggressive OBR, including enfuvirtide at the beginning, and then pushing the exposure to dolutegravir, and try after to simplify this complex regimen. And so I think that many factors could be there, including possibly the inhibition of GP120 like as a factor involving in this process. I would like to conclude, say the more important thing. The CD4 are really, really high, and we have able to cure HIV infection. No requirement of opportunistic infection prophylaxis. And now the patient will be vaccinating again as per zoster, because it's the problem this patient have in the past. So concluding, we know that low CD40 cell is frequent in HT patients harboring a multi-drug resistant virus, and this today associated with a risk to develop AIDS and non-AIDS event. We know the CD4 nadir is an independent predictor to become HT, and we know that we see achievement and maintenance of undetectable viral load is associated with good recovery, even in trials of HT patients. And the robust CD4 recovery we have observed in the BRIGHT study deserve further investigation. I would like to thank all of you and the Prestigio Registry for having this collaboration active in Italy. Thanks a lot for your attention.